My name is Colin. I'm Professor of Cardiology at the University of Glasgow, and I'm a cardiologist based at the Golden Jubilee National Hospital in Clydebank. I would like to tell you about the British Heart Foundation funded CORMICA clinical trial that we have recently conducted. CORMICA addresses the conundrum of patients having chest pain with clear coronary arteries. More broadly, CORMICA sits within ischemic heart disease. Ischemic heart disease causes angina, chest pain, heart attacks, and even ultimately heart failure and premature death. Ischemic heart disease is the leading #1 cause of premature disability and death in Scotland, in the United Kingdom, and actually worldwide. It's a major public health problem. And CORMICA addresses this subject. Stable angina is a common problem. In the United Kingdom, there are approximately 1 million attendances at chest pain clinics and hospitals every year. Ischemic heart disease is associated with a burden on society and the NHS, costing approximately £1 billion each year. Many patients presenting to a chest pain clinic actually do not have a blocked heart artery. Imaging with a CT scan reveals a blockage in patients with stable chest pain in approximately 1 in 5 to 1 in 4. So what are the causes of the chest symptoms in the majority of patients attending these clinics? Well, there have been suspicions that it may be due to small vessel problems. Imagine a tree, the trunk of a tree. The heart has got 3 main arteries, these being the tree trunks. But then there are the many small vessels, if you will, the many branches of the tree that we actually cannot see. And this is certainly the case if you image with a heart scan, such as a CT scan, or further down the line, an invasive coronary angiogram. So doctors are not well placed at determining whether chest pain is due to the small vessels when the tests don't have the resolution to reveal whether there may be problems in the small vessels. So CORMICA addresses this problem. CORMICA addresses patients who have been referred by doctors for a coronary angiogram, that's in passing a thin catheter via a blood vessel in the arm or the leg, passing dye into the heart arteries to look for blockages. It turns out that in many hospitals in Scotland, the UK, worldwide, about half of all patients undergoing this diagnostic procedure have clear coronary arteries. And that leaves the diagnosis, the onward management, uncertain. Moreover, this means that many patients are going through coronary angiography without a clear treatment plan, without a clear explanation, and they may reattend hospital or indeed become unwell with even a heart attack at some point because perhaps the diagnosis and the treatment wasn't effectively made in the first place. Now, research into small vessel disease in the heart has been going on for many years, and there's a great deal known about this problem. We benefit from the science on small vessel function and potentially even the treatments. But the problem or the conundrum is if the diagnosis isn't made, then the treatments cannot be used effectively. To date, there has never been a randomized trial comparing standard management based on angiography compared to the use of specific tests to measure small vessel function. Now, a randomized trial aims to mitigate out bias. In other words, to balance the care and management of patients, with the only difference being the use of these specific tests. And the allocation of the tests is distributed at random. So in CORMICA, we ran a randomized study comparing the routine use of specific tests to measure small vessel function, and with the results of these tests linked to treatment in patients with no obstructive coronary narrowings or no blockages in the heart arteries, as revealed by the angiogram. Sounds a little bit complicated, but in practice it was fairly straightforward. The study was based in the Golden Jubilee National Hospital in Clydebank, and it was funded by the British Heart Foundation. The study was embedded into routine clinical care and led by one of our clinical PhD students, Dr. Tom Ford. He was well supported by all of the staff in the department, including the doctors who routinely undertake the coronary angiograms, and importantly the nursing staff in the cath lab and also on the wards. Patients were given a written information sheet. They were given this sheet either before coming to hospital or just on the day of the procedure, and they were given sufficient time to consider the information, and if they felt in a position where they felt sufficiently informed, they would give informed consent. And that was specifically that if the standard angiogram revealed no blockages, then they would enter into the study and be randomized or randomly assigned to having the test results disclosed versus not disclosed. To put in other words, we measured the small vessel function in at least one heart artery in all of the patients, but the results were disclosed to the doctors in half. This is a form of a sham-controlled procedure. So this means that the patients and the doctors weren't entirely clear about the results of the tests, and all other things were equal except the disclosure of the test results in the intervention group. Thereafter, we found that treatment decisions were changed commonly compared to management based on the angiogram only. We found that this led to changes in patient satisfaction. The results based on questionnaire evaluations showed that the patients had got more insight into their diagnosis. This led to less uncertainty and greater satisfaction. This was just shortly after the procedure. And then we kept in touch with the patients, and at 6 months, the results of the Carmichael study disclosed that angina was less in terms of severity and frequency, and quality of life was greater in patients whose management was guided by the small vessel function test results. Now, this study was conducted over a 12-month period involving the Golden Jubilee Hospital and laterally here Myers Hospital in a neighbouring region in Lanarkshire. We enrolled 391 patients, of whom 151 had clear coronary arteries. There were actually another 35 or so who also had clear arteries, but weren't able to go into the study for logistical reasons. So actually in the study, again, consistent with findings elsewhere, half of all patients having a coronary angiogram had no blocked heart arteries. Still, this is constrained in scale. It was over 1 year, mainly in one hospital with 150 patients. And this study perhaps proves the concept, but the results need to be re-examined in other hospitals, ideally through another study, to ensure that there is external validity. In other words, that these results would be consistent in other healthcare systems in the United Kingdom and perhaps worldwide. Should that be the case, then the small vessel function tests could be considered as a new routine approach to the diagnosis and treatment of patients with angina.